Good morning. It's a pleasure being here along with my colleague, Dr. Kellerman, in hematopathology, to walk you through this NCCN Tumor Board webinar, specifically focusing on myelofibrosis, as well as the new NCCN guidelines in the therapy of myelofibrosis that we hope will be helpful in the care of these diseases. So perhaps to begin with, let's start with a case so that we can, as we follow the different decisions that we make regarding diagnosing, prognosticating, and developing a treatment plan for patients with myelofibrosis, what are the factors that we consider? So let's take a 63-year-old gentleman. He comes in to see me, and he's had 6 months of worsening fatigue, abdominal fullness, and night sweats. We find he's heavily symptomatic. He has a score of 40 out of 100 on the current patient-reported outcome form, the MPN 10. He has significant splenomegaly, 10 centimeters below the left costal margin. He has mild anemia, leukocytosis. Platelets are normal, 2% myelocytes in the peripheral blood. His bone marrow shows 3+ reticulin fibrosis, a karyotype of 20q-, and he is diagnosed with primary myelofibrosis. So how do we diagnose this gentleman? How do we think about prognosis? How do we come up with a treatment plan? So I've had the honor and privilege of being able to chair the first NCCN guideline panel focusing on patients with myeloproliferative neoplasms. It has long been a goal of many colleagues in the NCCN and I to try to bring forward guidelines for these diseases, given the rapid evolution of new information, new therapies, and indeed, hopefully, guidance that can help to both homogenize and improve the quality of MPN care around the United States. So these are the guideline panels which contributed to this, which include many of the key opinion leaders for the diagnosis and care of MPN patients in the United States. Now, as an initial set of guidelines, there were many unmet needs, so we decided to develop the guidelines in a sequential fashion, given both the volume of effort required as well as somewhat the different challenges in each of the segments. First, we thought it important to develop diagnosis and treatment response criteria for myelofibrosis, polycythemia vera, and essential thrombocythemia, really trying to set the stage for the eventual treatment guidelines, as well as an assessment regarding disease burden and treatment planning for all three of the classic Philadelphia chromosome negative myeloproliferative neoplasms. There are, of course, parallel guidelines both for chronic myeloid leukemia as well as for myelodysplastic syndrome. So these were really meant to fill that gap in between those other myeloid disorders. The treatment guidelines began with myelofibrosis very specifically. We will share that we are working on the treatment guidelines for polycythemia vera and essential thrombocythemia as step 2, anticipated to have those developed sometime in mid-2017. And then the final step will be the atypical myeloproliferative neoplasms of hypereosinophilic syndrome, systemic mast cell disease, etc. So we hope at the conclusion we'll have a complete set of guidelines. Then, of course, we'll evolve to the maintenance phase of guidelines that get revisited at a periodic interval or when new therapies are developed or approved. At a high level, as we begin with these guidelines, we wanted to add clarity where there was lack of clarity or consensus, to review evidence, but also to acknowledge areas that have already been largely brought into practice, both domestically for us in the U.S. as well as internationally. And with this, we identified that there had been some important work already done that we just wish to acknowledge and include as part of the guidelines. First, that my colleague Dr. Kellerman will taking us through in a moment, that the diagnosis of MPNs has evolved to really rely on the World Health Organization criteria with several different iterations, the most recently published this year. Next, we'll discuss the impact of assessing disease burden and symptom burden through now validated measures of patient-reported outcomes, and finally, how we consider prognosis. And with this, I'll hand it to my colleague, Dr. Kellerman, to walk us through the diagnosis of myelofibrosis.
Good morning. This is Dr. Katalin Kelemen, and I will summarize the pathology findings. As you probably all know, the WHO classification of the myeloproliferative neoplasm underwent a major revision just this year in 2016. And the rationale for a revision was quite disease-specific, but in the case of primary myelofibrosis, the goals were twofold. First, to incorporate new disease-defining mutations, especially the calreticulin and other mutations, into the diagnostic criteria. And second, the WHO emphasizes distinguishing morphologic features, especially to differentiate between early PMF and essential thrombocythemia. So in the same thought process, this is the first time that the WHO offers different criteria for a prefibrotic primary myelofibrosis, as summarized in this table, and for an overtly fibrotic primary myelofibrosis. Let's look at the first table. So for a prefibrotic stage primary myelofibrosis, we have 3 major criteria and 3 minor criteria. The diagnosis requires all 3 major and at least 1 minor criterion. Let's look at the criteria. The first criterion targets the bone marrow findings. We need to see megakaryocyte proliferation with atypia, but the reticulin fibrosis is still early. It cannot be more than grade 1. We also have to see a granulocytic proliferation with decreased erythropoiesis. The second major criterion is to alert the pathologist to make sure to rule out other myeloid disorders. Many disorders on this list can mimic primary myelofibrosis. The third criterion relates to the molecular findings. And we need to have at least one of the 3 major driver mutations, such as JAK2 V617F, a calreticulin mutation, or a MAPLE mutation. And this is now completely new in the classification. In the absence of one of these major mutations, one of the additional mutation can be accepted as criteria for clonality. And one of the 7 listed mutations could play this role here. Minor criteria include anemia, leukocytosis, and palpable splenomegaly. How does this change when we get to the diagnosis of a fibrotic primary myelofibrosis? Here we have 3 major criteria and 5 minor criteria. The first major criterion, the bone marrow findings, still include a megakaryocyte proliferation with atypia. But this time, by definition, we have a more advanced reticulin or collagen fibrosis, at least grade 2 or grade 3. The second and the third major criteria are the same. And for the minor criteria, we get 2 additional criteria, increased LDH and leukoerythroblastosis. Again, we need at least 3 major and 1 minor criteria for the diagnosis. Now that we know the criteria, let's review the peripheral blood and bone marrow findings in our patient, case 1. As Dr. Meza described, his peripheral blood showed anemia and an absolute neutrophilia with a granulocytic left shift. Here you can see segmented granulocytes and metamyelocytes, myelocytes, and even occasional circulating blasts. As for red blood cell findings, we can see a normocytic anemia, many teardrop forms or dacrocytes. These are the direct consequence of the bone marrow fibrosis. And also increased polychromasia and circulating nucleated red blood cells, completing the picture what we call a leukoerythroblastosis. This patient had a dry tap. There was no aspirable bone marrow aspirate. The core biopsy shows osteosclerosis characterized by ragged, irregular surface of the bone and evidence of remodeling of the bone surface by osteoclast and osteoblast. The bone marrow itself is fibrotic, but we can still recognize clusters of highly atypical megakaryocytes here and there. If we revisit the bone marrow composition on high magnification, we would see that the vast majority of the maturing elements are of the granulocytic lineage here, and the erythropoiesis is significantly decreased. This is a reticulin staining applied to the same bone marrow. You can see a diffusely increased dense reticulin fibrosis composed of many parallel and also branching arborizing fibers. This is at least grade 2 or even grade 3 fibrosis. In the next two slides, I will summarize the recommendations for myelofibrosis grading. The WHO currently recommends 4 grades, 0, 1, 2, and 3. And the pathologist uses a reticulin stain and meson trichrome stain to highlight the reticulin and collagen fibers respectively. A grade 0 reticulin fibrosis is basically normal bone marrow. In the normal bone marrow, we only have a few delicate fibers here around blood vessels, and a few scattered delicate linear fibers are acceptable. In grade 1 reticulin fibrosis, we have loose network of reticulin with some intersections, but this is still just a very delicate network. And in both grade 0 and grade 1, the bone marrow is readily aspirable. The difference between grade 2 and grade 3 myelofibrosis is mainly in the amount of the collagen. In both grades, the reticulin fibers are already very dense in both parallel and branching fashion. In grade 2, we can have some delicate and narrow collagen fibers running through the bone marrow, but the presence of extensive or coarse collagen fibers means a grade 3 fibrosis, as you can see on this image. And a rule of thumb that a diffuse grade 2 or grade 3 reticulin fibrosis results in a dry tap. So now just one more time to emphasize the important aim of the WHO of how to use clinical pathologic criteria to differentiate between an early PMF and essential thrombocythemia. I summarize some of the helpful features in this table. As you can see here, in prefibrotic PMF, the bone marrow is hypercellular, already very early, while in ET, the bone marrow is expected to be normocellular. Megakaryocyte proliferation is present in both conditions, but higher degree of atypia and greater variability is seen in PMF, as opposed to ET, where the megakaryocytes supposed to be more uniformly mature appearing with less variability. Granulocyte proliferation and decreased erythroid lineage are features of PMF. ET should show quite normal granulocyte and erythroid lineage representation in the bone marrow. Anemia, leukocytosis with neutrophilia, and palpable splenomegaly all favor primary myelofibrosis, and these features should not be present in essential thrombocythemia. And of course, we understand that all these criteria are not present in every case, but any of these features or any combination of those should facilitate a diagnosis of prefibrotic primary myelofibrosis, which of course has a great prognostic significance as opposed to essential thrombocythemia. And with that, I show you two snapshots of two bone marrows. The first is from a patient from a prefibrotic PMF. And this is a middle-aged individual, so we can see that the bone marrow is at least slightly hypercellular. There is a megakaryocyte proliferation, and you can observe the great variability. There are small, medium-sized, and large complex megakaryocytes. And the background shows a granulocyte expansion and decreased erythropoiesis. Now here is a similar age individual with ET. Here the bone marrow is normocellular. The granulocytic and the erythroid lineage is essentially normal. There is megakaryocytic proliferation with less variability. I hope that this summary is helpful, and with that, we can return to the clinical discussion.
Well, great. Well, Dr. Kellerman, a wonderful discussion on the diagnosis. And as many of you, I certainly rely heavily on our close relationship with my colleagues in hematopathology for us to be able to care for these patients together. Indeed, the features can be sometimes challenging, and I find in this evolving era, in particular, individuals that have overlap syndromes can be a challenge to accurately diagnose, as well as other challenging scenarios, sometimes trying to differentiate things such as MDS with fibrosis versus those with myelofibrosis. And as we try to highlight, that differentiation between essential thrombocythemia and early myelofibrosis is a particularly challenging one, but an important one to be mindful of. So the next stage, the patient's been diagnosed, is to get an accurate assessment of the risk the individual faces. As we speak of risk in patients with myeloproliferative neoplasms, there are several types of risk we really are mindful of. Is it risk of vascular events? Is it risk of progression? Is it risk really of mortality associated with the disease? Most of the published data is really regarding the risk of mortality when it comes to myelofibrosis and regarding the risk of vascular events when it comes to ET and PVERA. That's a discussion we'll have a different day. But for myelofibrosis, let's focus on the issue of mortality. And those factors that have been helpful have included a variety of prognostic scores. They do overlap with some of the lessons learned from our other diseases in terms of risk scores used from CML, such as the SOCOL, or the IPSSR in myelodysplastic syndrome. And certainly it includes, one, the impact of the disease on blood counts. So anemia, clearly patients do worse. Leukocytosis, increasing age, constitutional symptoms, and the presence of blasts. So this tells us a variety of things: movement toward acute leukemia, disease burden, cytopenias, age. All are adverse factors. And with that, we could stratify folks between low, intermediate 1, intermediate 2, and high risk. This is for the DIPSS, which can be applied at any point during the disease course. My colleagues at Mayo Clinic in Rochester helped to refine this further with the DIPSS Plus, which includes, in addition to those pieces of cytopenias, symptoms, etc., the consideration of an extra level of concern if one is red cell transfusion dependent or thrombocytopenic, as well as those with an unfavorable karyotype. Again, recognizing these are a core chronic myeloid disorder, and the other lessons we've learned in myeloid disorders, such as MDS, CML, and even AML, certainly apply. As we think about disease burden, it not only includes risk of mortality, but it does include the impact of issues such as the cytopenias themselves. Do they exacerbate comorbidities? My patient that's transfusion dependent, is that an individual with heart failure, in which that is a big burden? Is that an individual that is well compensated? There's the burden of splenomegaly, likely from ineffective extramedullary hematopoiesis. There's a real symptom burden that we think is cytokine-based and a real link to the biology of the disease. And finally, we need to be mindful of individuals' baseline health. Their comorbidities, their other medications are very relevant as we care for them. Now, with the guidelines, we, one, have that diagnosis which we discussed, the WHO. Two, an assessment of symptom burden. And suggests the use of this 10-item scale that we've now validated in about 5,000 patients and have it in 16 different languages. And with this, we have been able to show that it is helpful in terms of assessing burden, but also monitoring response to therapy when it comes to the symptom burden that these individuals face. Using such a score, we're able to identify, and this is data in 2,000 patients on this graph, that on the left, patients can have a significant prevalence of symptoms as well as significant severity. Patients in green with myelofibrosis are the most symptomatic. What's a surprise to folks is how symptomatic subsets of patients with ET or PVERA can be. So let's look at the guidelines as relevant for this individual with intermediate 1 risk disease. So we diagnose the individual, and by risk, there are 3 different risk scores one can use. They all are equivalent in this regard. IPSS is at diagnosis. The DIPSS plus, if you have a karyotype, you can calculate that, or the DIPSS, which can be used without a karyotype. You assess symptom burden. So now at this point, you have an idea how symptomatic is the patient, what is their risk. Here, we then decide on our treatment option. Now, clearly, the treatment option, we try as guidelines to highlight the decisions that we think are both evidence-based and helpful for these patients, but there's still individualizing factors. So intermediate 1 is probably the most diverse. If an individual is intermediate 1 only because of age, perhaps observation is appropriate. If an individual is significantly symptomatic, ruxolitinib, the JAK inhibitor, might be a strong consideration. Always, throughout any point in myelofibrosis, if there's an appropriate clinical trial for their stage, that is reasonable given the lack of curative medical therapy. Or individuals, if they have high-risk molecular features, allogeneic stem cell transplant is a consideration, clearly dependent upon the age of the individual, who the donor would be, their risk, which you calculate out, as well as comorbidities. We then monitor for response as well as progression, and if we have progression, we move to the higher risk algorithm. If not, we will consider perhaps recycling to one of these alternative options. Now, what about these higher risk molecular features, which I alluded to? So there's 2 different sets. One, if we look at the driver mutations, JAK2, MPL, or CALR, they all can be present in myelofibrosis. About 80% of patients with myelofibrosis will have one of these 3 mutations. Individuals that lack any of these 3 mutations have an adverse prognosis, and that is a consideration regarding decision-making in stem cell transplantation. There are additional somatic mutations that we can get with more extended next-generation sequencing panels that have adverse prognostic implications. I expect that this list will continue to evolve over time as more is learned. But in particular, ASXL1, EZH2, IDH1 and 2, all of these are associated with inferior survival and are being considered at the moment regarding the issue of stem cell transplantation. P53 mutations. So all of these, it's a very much of an evolving set of considerations that are the most impactful regarding our decision-making for stem cell transplant. My colleague Alessandro Vannucchi had tried to combine both these clinical features as well as molecular features in a new molecular score. It's not been fully validated yet, but this is the movement to try to incorporate both clinical and molecular features into one score. Where that's relevant is potentially being able to better subdivide individuals that had historically had low risk or intermediate 1 risk disease. As we think about our case, if the individual has those higher risk molecular features, their survival drops to about 8 years, and transplantation is a stronger consideration, whereas those without it have a much better prognosis. Now, what is symptomatic? Again, somewhat in the eye of the beholder, but on data we just presented at EHA and then updated at ASH just last week, we identified on this 0 to 100 scale patients with MF that have a total symptom score of greater than 20 or a single item of greater than 5 as being significantly symptomatic and being linked with higher risk disease features. So let's look at this individual. The one we presented had significant symptomatic disease, was intermediate 1 in risk, and in terms of disease burden had both symptoms and splenomegaly. This individual was begun on ruxolitinib, and we're monitoring for blood counts, changes in spleen size, as well as changes in the symptom score. 4 months after therapy, it had a nice reduction in the size of the spleen. The hemoglobin is slightly lower. The platelets are slightly lower, as might be expected with the side effects of that medication. However, the symptoms are quite a bit better. We have increasing data regarding the use of ruxolitinib in individuals with intermediate 1, which is why the panel made this recommendation. One such example is a trial done in the United Kingdom where individuals with intermediate 1 risk disease were included along with those with intermediate 2 and high risk disease. The interim results of this study showed basically equivalent responses for splenomegaly and symptoms in individuals with intermediate 1 risk disease as those with intermediate 2 and high risk disease. So one did not need to stratify therapy based on the presence or absence of intermediate 2 versus intermediate 1. Additionally, in the expanded cohort of the JUMP study, which was open-label ruxolitinib prior to approval in a variety of countries, data with intermediate 1 risk patients was overall as favorable in terms of response as well as safety compared to those utilized or individuals which had been enrolled in the COMFORT 1 and COMFORT 2 studies. So I'd say the takeaway points from case 1, an accurate WHO diagnosis of myelofibrosis with assessment of long-term risk by IPSS, DIPSS, and symptom burden is both suggested and we hope clinically useful. A broad range of options from observation in asymptomatic to allotransplant if high-risk molecular features are considerations, and intermediate 1 risk is probably the most diverse of the options available to us. Ruxolitinib has solid, albeit non-randomized control data in individuals with intermediate 1 risk disease and worthy of consideration in those with splenomegaly and symptoms. Let's move to our second case. 59-year-old woman diagnosed with PVERA at age 45 with a pulmonary embolus. Managed with phlebotomy, aspirin, and hydroxyurea, she now has lost 4 kilograms, has bone pain, low-grade fevers, and no phlebotomies for the past 3 years. You'll see that she's highly symptomatic, big spleen, anemic, significant leukocytosis. Bone marrow shows 3+ reticulin fibrosis, karyotype of 46XX. She has post-PV myelofibrosis. With that, let me hand it over to my colleague, Dr. Kellerman, to review. Before we can accurately diagnose someone with post-PV myelofibrosis, we have to be sure they have PV.
Thank you, Dr. Meza. Again, in this table, we can see the revised WHO criteria for PV. Based on the data of the last 8 years, since the latest WHO classification came out, it became evident that many patients were probably underdiagnosed with PV because the hemoglobin cutoff was too high. So the WHO revised the major criterion for hemoglobin and hematocrit diagnostic cutoffs. And the new recommendation is 16.5 gram per deciliter for men and 16.0 gram per deciliter for women. The hematocrit values were also adjusted. The second major criterion is the bone marrow biopsy findings. In PV, the bone marrow is hypercellular and it shows tri-lineage expansion, what we call panmyelosis. The megakaryocytes can appear quite pleomorphic in PV, and that doesn't mean that they have primary myelofibrosis as long as the erythroid proliferation is present. The third major criterion relates to the molecular findings, and here the JAK2 exon 12 mutation was added to complement the JAK2 V617F mutation. There is only one minor criterion in PV, and that's the subnormal serum erythropoietin level. The diagnosis requires all three major criteria, or if we don't have a JAK2 mutation, then we can incorporate the minor criterion of the subnormal serum erythropoietin levels. So the pathology findings at diagnosis of polycythemia vera usually involve erythrocytosis, and we can see a patient with erythrocytosis and normochromic normocytic red blood cells in the peripheral blood, but in fact in the clinical practice we commonly see them with already iron deficiency anemia, and this is a representative peripheral blood smear with a patient who had PV erythrocytosis but already developed iron deficiency anemia. And here you can see full-blown pictures of the iron deficiency with delicate hypochromic hemoglobin rings, many ovalocytes, some dacrocytes, and red blood cell fragments. And we commonly also see thrombocytosis in polycythemia vera. The bone marrow at original diagnosis is hypercellular, and it shows a tri-lineage proliferation. What this really means that in the background we see increased erythroid islands. Either the myeloid to erythroid ratio is normal, so they are increased proportionately, or sometimes even the erythroid lineage predominates. But there is no diagnosis of PV without erythroid expansion in the bone marrow. Now let's compare these findings to our patient in case 2. We know that this patient already has 14 years of history of PV. So we no longer see the original criteria. The peripheral blood, in fact, shows anemia as opposed to erythrocytosis. And there is neutrophilia with granulocytic left shift, metamyelocyte, myelocyte, and even rare circulating blast. The bone marrow was a dry tap. There is no bone marrow aspirate. The core biopsy is hypercellular and shows large clusters of megakaryocyte as a landmark of a myeloproliferative neoplasm, but the background shows a quite advanced fibrosis as characterized by this spindly appearance of the cellular element and a lot of pink substance, which is the fibrotic material in between and among cells. We can still see collections of proliferating granulocytic elements and large proliferating erythroid islands. So there's still a panmyelosis. A reticulin fibrosis highlights at least grade 2 or grade 3 reticulin fibrosis in this bone marrow. So it is clear that in this stage, the pathologists cannot apply the original well-known diagnostic criteria of PV. Instead of erythrocytosis, there is anemia. Instead of thrombocytosis, there is thrombocytopenia, and there is this leukoerythroblastic picture. Plus, there is no bone marrow aspirate to evaluate. The bone marrow is fibrotic and distorted. In other words, all the well-known, well-learned criteria no longer apply. So does that mean that there is no role for pathologic evaluation at this stage? No, it doesn't mean that. In fact, the bone marrow evaluation is still very important. Just the purpose, the aims are somewhat shifted. First of all, it's the pathologist's responsibility to establish, are the bone marrow findings compatible with a myeloproliferative neoplasm with myelofibrosis? Let's keep in mind that there are many conditions which can mimic myelofibrosis, such as hairy cell leukemia, systemic mastocytosis, or just about any spindle cell neoplasm. Another important question for the pathologist, is it possible that after long-standing disease, this patient already is presenting in a stage of acute leukemia? So we have to rule that out. And then finally, myelodysplastic syndrome has a subtype which is associated with myelofibrosis, and of course that is very important to consider and to rule that out. The second role for the pathologist at this stage, to establish the myelofibrosis grade. And as we described, you can see that the myelofibrosis grading is, for the best, is semi-quantitative and can be quite subjective. So the best result is expected if the pathologist can compare serial biopsies over time and evaluate the dynamics and the progression. And then finally, I would like to emphasize the importance to facilitate ancillary testing when there is no cellular bone marrow aspirate. Either fresh core biopsies in saline or peripheral blood samples can facilitate ancillary testing for cytogenetic and molecular data.
Well, that was a wonderful discussion regarding the features to keep in mind, not only in terms of diagnosing P-Vera, but really how we look at progression. Now, for this individual, as I try to look at folks, I think about both their risk and their disease burden. In terms of risk, this is an individual that has very high-risk disease in terms of symptoms, anemia, leukocytosis, and blasts. As we think about disease burden, they similarly have a heavy disease burden, symptoms, splenomegaly, and anemia. They've not yet moved toward acute leukemia, but of course that remains a risk. This individual does not have an initial donor. Transplantation is a key consideration that we'll discuss, and therefore begins on medical therapy. So how do we approach these folks? So this individual has high-risk disease. We're mindful of symptoms. We're mindful of the risk of disease. Our first question is, are they a transplant candidate? And if so, is that a consideration based on the presence of a donor, the patient's wishes, etc.? At the moment, this individual does not have a donor. They're not a transplant candidate. We stratify based on whether they're primarily anemic alone, of which we have a sub-algorithm for those individuals, or the vast majority, let's say about 85 to 90% of this group really fall into this stratosphere, not a transplant candidate. Here, the panel chose to stratify based on the randomized phase 3 data as well as current label of ruxolitinib. Individuals with a platelet count above 50,000, ruxolitinib is reasonable starting therapy. However, if there's an appropriate clinical trial for frontline, that too is a consideration. Such an example would have been the recent Simplify-1 study, momelotinib versus ruxolitinib as frontline therapy. Less than 50,000, off-label ruxolitinib can be considered. However, a clinical trial is an important consideration in this difficult group. Individuals on ruxolitinib, we monitor for response. We monitor for evidence of disease progression. Response, we continue treatment. No response, again, we circle back, or we consider disease progression or clinical trials. The majority of clinical trials currently in the United States are for individuals exactly in this group that have had a suboptimal response to ruxolitinib. So ruxolitinib as core therapy, how did we evolve to this point? The COMFORT-1 and COMFORT-2 studies were reported now over 5 years ago, which showed significant benefit in terms of reducing splenomegaly compared to placebo, intermediate 2 and high-risk disease, as well as improvement in symptoms, both individual symptoms improving, such as itching, night sweats, weight loss, as well as symptoms in aggregate. Long-term data I presented on behalf of our colleagues at ASCO this year, and we saw significant improvement in splenomegaly that is durable, almost 5 years out, whether individuals received ruxolitinib to begin with or crossed over on this randomized study. We continue to see a survival advantage, likely deriving from the decreased morbidity associated with the disease. Patients with myelofibrosis who have not transformed to acute leukemia die of debilitation with the disease. They die of pneumonia, they die of heart failure, they die of a series of complications. 5 years out, non-hematologic toxicities, there's no surprises. We see low-grade events, fatigue, etc., which can occur. Some of these are disease-related, so a bit difficult to separate. Ruxolitinib clearly can cause cytopenia, so that's probably the main lesson learned over time. There is an initial drop in the platelet count, however, that tends to stabilize after 12 to 24 weeks of therapy. Patients can have an additional nadir in terms of anemia that tends to improve over time, although perhaps not coming back to baseline. Over time, we've learned more regarding dosing of the medication and starting at a little bit lower dose, such as 10 milligrams twice a day, with an increase after 24 weeks to diminish the impact of anemia. Long-term, a couple cautionary notes. One, there is an increased risk of non-melanoma skin cancers. It's difficult to know the contribution of the risk of disease as well as prior hydroxyurea exposure in this factor, but it's something that needs to be considered and is in the label. Additionally, there is a slightly increased risk of herpes zoster in this group of patients. Now, there are new therapies in development, and where might they fit? At a high level, momelotinib and pacritinib are agents with mature phase 3 data, potential activity for individuals with anemia or thrombocytopenia. There's a possibility that if approved, they may well have an impact in a segment of patients with baseline cytopenias in myelofibrosis. Several agents are really being tested in the second-line setting. Both momelotinib and pacritinib have maturing data, as well as the anti-fibrosing agent PRM151 and the telomerase inhibitor imetelstat. So this individual, this case that we discussed, he lacks a well-matched donor. Begins on ruxolitinib as a response to symptoms and splenomegaly. Now, 3 years later, presents with epistaxis and dyspnea on exertion. Now their counts are quite a bit more severe. They're quite anemic. Leukocytes are 0.9%, but the majority of cells which are seen in the peripheral blood appear to be blasts. Markedly thrombocytopenic. The spleen, however, is about similar in size. So with that, always a concerning call from your hematopathologist. I sometimes get such a page on in the morning by a very perturbed Dr. Kellerman. So let me have her walk you through the slide.
This is a peripheral blood smear I would be certainly calling Dr. Meza about. The patient now has pancytopenia in terms that there is anemia, thrombocytopenia, and absolute neutropenia. There is only just one segmented neutrophil in the whole field. But what the patient has in excess is blasts, and these are mononuclear cells with high nuclear cytoplasmic ratios, finely dispersed chromatin, and occasional visible nucleoli. This patient had 60% circulating blasts. This time, a bone marrow biopsy was performed and the aspirate was cellular. Again, 68% blasts were found by differential count. The blasts are these mononuclear cells with fine chromatin. The flow cytometry demonstrated a myeloid immunophenotype. In other words, we diagnosed an acute myeloid leukemia transformation in this patient. This is a representative image of the bone marrow core biopsy. It is 100% cellular and essentially replaced by sheets of blasts. Again, these are the mononuclear cells with the prominent nucleoli and high rate of mitotic figures. In the background, you will still see a large distorted cluster of megakaryocytes as landmarking the background of a myeloproliferative neoplasm. Well, there are important diagnostic challenges in the blast phase of a myeloproliferative neoplasm, and these challenges are primarily derived from the fact that often the patients don't have a cellular bone marrow aspirate. There is a very important role in monitoring the circulating blast percentage over time in these myelofibrotic patients. And we do this in this institution regularly in a 3 to 6 months interval. Once we see the peripheral blood blast percentage over 10%, we are alerted that the patient may be entering a progressive or accelerated phase. And beyond 20% blast in the peripheral blood, basically the patient meets criteria of acute leukemia. Let's keep in mind that sometimes we can have alternative methods of seeing increased blast in the bone marrow, such as touch preparations of a fresh core biopsy may be helpful. And the bone marrow core biopsy is often difficult because it's so fibrotic and distorted. It could be very different to tell which cell is a blast and which is a maturing cell. Therefore, there is an important role for immunohistochemistry Here is one of our patients who had a dry tap. He was pancytopenic with just a very few blasts in the peripheral blood. But the bone marrow was hypercellular, and a CD34 immunostain was very helpful, highlighting more than 20% blast in his bone marrow. Not just CD34, but CD117 can be also very helpful and facilitate the diagnosis of an acute myeloid blast transformation. Back to Dr. Mehta.
So clinically, this is one of the most difficult groups of patients for us to manage, in that their prognosis continues to be very guarded. Indeed, my colleague Serge Versavchik and one of the panel members just had an abstract at ASH last week, which shows that the survival of these patients continues to be very dismal and indeed very difficult to get them through therapy. The panel identified that it's important to work these patients up like an AML, as well as all of the factors that Dr. Kellerman raised, as well as be mindful of AML-associated mutations. We're mindful that they may have slightly two different sets of prognosis, those with blast 10 to 19% versus above 20%. However, the management question remains fundamentally the same. Is this an individual that has a trajectory to stem cell transplant based on the age, the presence of a donor, etc., or is that not an option? Those that have a transplant option, we need some degree of cytoreduction likely for transplant to be successful, given the high rates of relapse or post-transplant relapse. Therefore, it is recommended either remission induction with hypomethylating therapy or intensive induction chemotherapy followed by allotransplant. Those that are not a candidate for transplant, clearly a clinical trial is a strong consideration. We refer you to the NCCN guidelines for the management of acute leukemia. Hypomethylating agents have certainly been helpful in helping to manage individuals that are suitable candidates. And it's probably our preferred off-label regimen for these groups of individuals trying to prolong survival. There probably is not a role for induction chemotherapy in non-transplant candidates, and that the rate of relapse is really about 100%. So this individual is found to have a haploidentical donor for allotransplant from her son. An evolution now much more of an option than it had been in the past. Step one, she was induced with mitoxantrone, etoposide, and cytarabine. Day 14, a hypocellular marrow. Day 25, neutrophils recover. Day 32, the marrow appears to be back to chronic phase post-PVMF. Here is the key part. In the individuals in which we've been successful in salvaging, the gap between successful induction and moving straight to conditioning for the transplant is brief, because the risk of relapse remains very high. This individual then is transplanted. They have neutropenic fever and C. diff colitis. They engraft day 22 and is alive with minimal to moderate GVHD day 165. So not an easy course. In the future, ideally, a course that we can avoid progression to AML, but when it occurs, an aggressive strategy has been helpful in salvaging a segment of patients. So as takeaway points, intermediate 2 and high-risk MF are a balance between decisions regarding allogeneic stem cell transplant and frontline JAK inhibitor therapy. New therapies in the pipeline for MF may expand medical options. Progression to accelerated or blast phase MF may be seen in blood or marrow and has a challenging prognosis. Only curative treatment of blast phase includes clearly an allotransplant. But clearly want to thank our group that focuses here on myeloproliferative neoplasia. For that, would like to very much give my thanks, on behalf as well of my colleague Dr. Kellerman, for your participation in today's